Hello everyone, and welcome to the third lecture of the AMC preparation course and the third part of the principles of dermatology. In today's lecture, we will speak about the examination of the hand. We will see some pictures of some changes that will occur in the hand, and we will speak about the associated diseases with them. But first of all, I would love to apologize for the last lecture I posted. I did mispronounce some of the medical terms that were in the lecture. But generally, I think we are humans. We do make mistakes, but we should admit that we've made mistakes and correct them. So here I am correcting my mistakes. So the first term I mispronounced was onculitis. Then we will have koilonkia. And I found a really nice note about measles. So if you watch Dexter or any crime shows, you know the forensics or the doctors that come to examine the body after someone found dead and they suspected a murder. So measles are actually important to know if the victim was poisoned or not. Measles and Piau's lines as well. I didn't mention Piau's lines in the last lecture, so make sure to look it up. And lentigo. So the first picture we have here, or the first condition, is Palmar erythema. So it is a asymptomatic redness of the palm, especially in the thinner area and hypothinner area. Why does this happen? It happens because we will have a hyperestrogenic state. We will have high levels of estrogen. Why will we have high levels of estrogen? Because we will have either chronic liver disease. This will impair estrogen metabolism. Estrogen metabolism happens in the liver, so we will have liver disease, no metabolism, high levels, accumulation of estrogen, or a pregnancy, because we know in a pregnancy we'll have high levels of estrogen. So we will have this redness in the palm, as well as some other conditions like thyrotoxicosis, but the most common are chronic liver disease and pregnancy. So this is a picture of the palmar erythema. It happens because the patient have cirrhosis. This is another picture of the palmar erythema. We can see it very clearly. It's a really good picture. Redness. So this is just a revision. This is the hypothenor area and its muscles. You can pause the video and read them, revise them. And this is the thinner area. Hypothenor. So the second condition we will have, it's hyperpigmentation of the palms. So we will have darkening of the skin of the palms, as we can see in this picture. The reason will be adrenal insufficiency or secondary hypercortisolism. So the most common one, to be honest, is adrenal insufficiency, just like Addison disease, which we will have very low cortisol level in the body. Yes, we will see hyperpigmentation of the palm. Maybe as I have another picture, just look up for your palm right now and see the difference. You will see, you will notice the hyperpigmentation better if you see a normal hand and a hyperpigmented hand. So this is hyperpigmentation. Then we will have Heberden nodes. So we will have these nodes in the distal interphalangeal joints. This one, 2, 3, 4, 5. Never mind that these are highlighted. These are the distal interphalangeal joints. These are the proximal interphalangeal joints. So we will have a formation of osteophytes in the joint, which is like we will have formation of bone in the joint, so we will have an impaired movement and pain. This is a very classical sign for osteoarthritis. This is a picture. You see here there's a swelling. If you actually I examined a real patient that have Heberden nodes. So if you touch it with your hands, we will feel like it's a bone. It's a very what do you call it? Not strong, solid thing to touch. It's a bone. See? And the distal interpharyngeal joint. This is another picture. It's very clear and it's really good when you examine the patient. When you palpate it, you'll feel it. Then we have Bouchard nodes. This time the Bouchard nodes will happen in the proximal interphalangeal joints. With the same thing, we will have osteophytes formation in the joint, pain, and impaired movement, and it's a classic sign for osteoarthritis. This is another. Here actually we can see maybe Heberden and Bouchard nodes, and this could be rheumatoid nodes, maybe. Yes, this is a rheumatoid nodes. So this is a very beautiful picture. And the distal one we will have Heberden nodes, and the proximal one we will have Bouchard nodes. These are rheumatoid nodules. Remember what the shape. We will have them in these places and the body. So if we have a symmetric, rheumatoid arthritis is an autoimmune disease, so it's a systemic disease. So we should have a symmetrical swelling of proximal and distal interphalangeal joint. This is a classic sign for rheumatoid arthritis, as we can see in this picture. 1, 2, 3, 4. 1, 2, 3, 4. It's a symmetrical between the two sides. Actually, this picture I found it in a case. It was suspected that she have rheumatoid arthritis or I forget the other one. It was differentiated between two things. So it was waiting for the test. Then we'll have swan neck deformity. So the finger will look like a swan neck. I hope you all know what is a swan. So it's a classic sign for rheumatoid arthritis. This is a swan neck deformity under the X-ray. Very clear. We have swan neck is a rheumatoid arthritis sign, by the way. I hope I mentioned it. Then we have an ulnar deviation of the fingers. So we'll have a displacement of the fingers toward the ulna. This is the ulna, this is the radius. So the fingers will go toward the ulna, and it's also a sign of rheumatoid arthritis. This is it's ulnar deviation under the X-ray. Then we will have Gottron papules. Gottron papules. So we will have erythematous papules on the external surfaces of the hand. So on the joint points, the external surfaces of the hand, the DIP, PIP, and the MCPs as well, we will see erythematous papules, and it's designed for dermatomyositis. Here's another picture. It's really clear. 1, 2, 3, 4, and all the external surfaces of the palm. Then we will move to the Dupuytren contracture. This is actually a French word named after a surgeon that discovered this. So it's pronounced like Dupuytren. Dupuytren. Today I brought you even French pronunciation. No more mistakes. Dupuytren contracture. I like the name. So it's a fibroproliferative disorders of unclear etiology, so it's idiopathic. So we will have fibroproliferation in the MCPs, and it will lead to the fingers to look in this flexed movement. It can happen to the 4th or the 5th digit. So this is the 4th and this is the 5th digit. In this case, we are seeing it in the 5th digit, and this is in the 4th digit. I think this one is clear, and it's idiopathic. Then we will have to the Janeway lesions. So what is important about it? First of all, it's non-tender. There's no pain with these things, and it's present on the palm and soles of the foot. Also possible to be on the fingertips, but mostly on the palms and the soles of the foot. And it's a sign for infective endocarditis, and it's caused by septic immobilization from the infected valve. Then we will have Osler nodes. these are actually kinda similar, but not very much. So the first difference here, these are painful. Janeway lesions are not painful. The second thing, these are present on the finger and toes tips. So this is the second difference. And this one actually are caused by immune complex mediated vasculitis. Here's another picture for the Osler nodes on the fingertips, on the toe tips, and actually another difference that I remember. These are flat lesions. These are raised lesions. So I made a small, the quick difference between them, the Osler nodes and Janeway nodes. Osler are painful. Osler, ouch, yeah. So it's raised red purple nodules. They are located on the fingertips and toes. They are caused by immune complex deposition and last for hours to days. Janeway lesions are painless, no pain, flat, red macules. Here we will have nodules located on the palmar soles and caused by septic emboli and last for days or weeks. These are the other difference on the tip, on the palm, raised, flat, and they are both indicate that we have infective endocarditis. And that's actually all for today's lesson. I hope you liked it, you learned something from it. Thank you so much for watching. I hope you have a great day. See you on the next lecture. Goodbye.
We are looking at how to pronounce the name of this disease, as well as how to say more. This was named after a historic Dupuytren, Guillaume Dupuytren. But it'd be fine in English to say it as Dupuytren's Contracture.